Hey guys, Dr. Carmen Bryant here with www.nursingschool911.net, back with another video, and today we're going to be talking about 3 different types of anemias. So we're going to touch on the causes, we're going to touch on a little bit about the underlying patho of each type of these anemias, obviously the clinical manifestations that you can expect, and then the nursing care and medical treatment. So we're going to talk about iron deficiency, B12 and folic acid deficiency, and aplastic anemia today. So first of all, let's just start off by talking about what is anemia. So anemia just means in and of itself a low oxygen carrying capacity, okay? And what carries oxygen throughout our body? Hemoglobin, which is found on the red blood cell molecule, okay? So all anemias across the board are going to have some very similar signs and symptoms, some clinical manifestations that are common because there's anemia present, so there's a low ability to carry and transport oxygen throughout the body. So some of these manifestations that you're going to see associated with any type of anemia are going to be dyspnea, okay, shortness of breath because oxygen is not getting circulated throughout the body. Fatigue, okay, low oxygen carrying capacity. Always going to see fatigue associated with any type of anemia. Increased workload on the heart, okay, so when the oxygen is not getting circulated around throughout the body because of anemia, that increases the workload of the heart, and in turn the heart compensates through tachycardia to try to get the heart rate up to compensate for that tissue hypoxia that the patient is experiencing because of the anemia. And then you may also have the patient complain of some dizziness, possibly some syncope, if the anemia is that severe, okay? So those are clinical manifestations. Those are signs and symptoms that you can expect across the board. So what is key when you're studying and learning to differentiate these anemias is learning the manifestations that distinguish each type of anemia from the other, okay? So that's what we're going to kind of focus on with this lecture, with this video. So starting off with iron deficiency anemia. So iron deficiency anemia is the most common type of anemia worldwide. There are some causes for iron deficiency anemia that are, common in this country. And that includes GI bleed, so blood loss from GI bleeds, GI ulcers, that sort of thing. With women, it's actually heavy menses or menorrhagia. And then you can just have, a low iron intake diet. So that's more common among, vegetarians. But really, blood loss is the biggest cause for iron deficiency anemia. And so why is iron so important? So iron is actually, we get iron from the GI tract, right? So iron is actually completely necessary in order for us to form functioning hemoglobin. Okay, so we take in iron from the GI tract, and iron binds with another enzyme within the body to form heme, which is actually the functional component of hemoglobin. All right, so without enough iron in the body, we're not going to have enough functioning hemoglobin. So we will have that low oxygen carrying capacity and all of the signs and symptoms, the dyspnea, the fatigue, the increased workload of the heart. We'll have all those things because of the low hemoglobin synthesis and production, because of the decreased iron intake or loss through blood loss, whatever. In addition, we will have some unique manifestations associated with iron deficiency anemia that you're not going to necessarily see, that kind of helps differentiate iron deficiency from the other types. You'll see things going on with the GI tract specifically. So you'll see things like stomatitis, which is kind of ulcerations within the GI tract. You'll see something called cheilitis, which is those very dry, cracked lips. And you'll see something called glossitis, which is a very bright red, or some books like to say a beefy red tongue. Okay, so the three itises with iron deficiency: stomatitis, cheilitis, and glossitis, which is what you'll see uniquely in addition to, the typical clinical manifestations that you'll see with iron deficiency anemia. What else will you see like on your CBC? So we talked about how without iron, we're unable to produce heme, and therefore we're going to have not enough functioning hemoglobin on our red blood cell. So when we're looking at our CBC specifically, obviously our hemoglobin and hematocrit are going to be low, okay? We can also look at something called the red blood cell indices, specifically MCV, which is mean corpuscular volume, and MCHC, which is mean corpuscular hemoglobin concentration, okay? So what do you think that those would look like in an iron deficiency anemia? Well, mean corpuscular volume just tells you the size of the red blood cell. It's going to be very low. So this is what we call a microcytic anemia, where MCV, or the volume, is low. We're also going to see a very low MCHC, or mean corpuscular hemoglobin concentration. So that would be hypochromic, okay? So the red blood cell is also very pale in color. So your red blood cell indices just tell you about the size and the appearance of the red blood cell, okay? So iron deficiency, in summary, is a microcytic because MCV is low, hypochromic because MCHC is low, type of anemia, okay? So you would see those red blood cell indices to further help you kind of differentiate this type of anemia from others on your CBC. So moving on to B12 and folic acid deficiency. So this is another type of anemia that can be resulting from, low intake of, folate, low intake of B12, not eating enough of your leafy greens, the organ meats, that type thing. But the vast majority of B12 deficiency is autoimmune. And when B12 deficiency results from an autoimmune cause, it's referred to as pernicious anemia. Okay, so what we have with pernicious anemia is that there are autoantibodies that are formed that attack the parietal cells of the stomach. Well, what do the parietal cells do? They produce something called intrinsic factor. And intrinsic factor is needed for the proper absorption of B12. Okay, so if we have these autoantibodies produced against the parietal cells and we don't have the intrinsic factor needed to absorb B12, then we will develop a pernicious anemia, or a B12 deficiency anemia. Okay, what's special about B12? What's special about folic acid? Both of these minerals are needed for DNA synthesis and condensation of our red blood cell, okay? So DNA synthesis and maturation and condensation of the red blood cell is the big role of B12 and folic acid. So keeping that in mind, going back to, how we need B12 to make our red blood cell fully mature and condense into that fully functional red blood cell, we're going to have a low oxygen carrying capacity if B12 is deficient, because we're not going to have a fully functioning, mature, condensed red blood cell. So we'll have all the signs and symptoms, the dyspnea, the fatigue, the tachycardia, all the signs and symptoms that you'll see with anemia. Additionally, thinking back to B12 and folic acid being needed for DNA synthesis and maturation, uniquely, we will have neurological manifestations. So some paranoia, maybe hallucinations, confusion. So neurological signs and symptoms accompany a B12 or a folic, not a folic acid, but accompany a B12 deficiency. You will not, hear me out, you will not see neurological manifestations if it is just a pure folic acid deficiency. But with B12 deficiency, with pernicious anemia, you will see neurologic manifestations, okay? In addition to all the other manifestations that are classically associated with anemia. Now, what else is important about B12 deficiency? So we talked about, the autoimmune aspect of those autoantibodies attacking parietal cells. You can have, or you can see a B12 deficiency in people with smaller stomachs. So think of people that have had like gastric bypass. They're at risk for pernicious anemia. Elderly, our elderly population, as their stomachs just kind of get smaller with age, they're at risk for pernicious anemia. So thinking about what you're going to see on your CBC, back to those red blood cell indices. So if we lack B12, if we lack folic acid that is needed for proper maturation and condensation of our red blood cell, we're going to have those blast cells that do not condense down and mature into a fully functional red blood cell. So we're going to have something called megaloblast, okay? So this is very unique to B12 deficiency. So megaloblasts, big, gigantic, non-functioning cells, okay, that were supposed to mature into red blood cells, but they don't. So our indices, what will they look like? This is going to be just a huge, big, gigantic blast cell. So this is what is called a macrocytic anemia, where our mean corpuscular volume, our MCV, is high, all right, because this blast cell is so large, all right. So this is a macrocytic as opposed to a microcytic form of anemia. All right, so that is basically B12. So how do we treat B12? Basically, we would give B12, right? But if they're not absorbing it properly through the GI tract, we'll have to give it IM. I don't think I mentioned treatment of iron deficiency anemia, but we'll give iron, right? Ferrous sulfate. And always remember to give iron on an empty stomach, sometimes with fruit juice. NCLEX and standardized exams love to ask those questions. So iron is best absorbed on an empty stomach, maybe with some, high citric acid content fruit juice like orange juice or something like that. That's one of the few things you can give orange juice with, right? And then with B12, you want to give IM B12 injections. If it's folic acid, you want to give them folic acid or folate, all right? So finally, aplastic anemia is the last type that we're going to talk about. And so it's kind of a misnomer because aplastic anemia is not an anemia that just affects red blood cells. Okay, aplastic anemia is one where the myeloid cell within the bone marrow is actually being attacked by something. 65% of aplastic anemias are idiopathic, meaning we really don't know what causes the aplastic anemia. But what happens is that either maybe it's a drug. Anticonvulsant drugs are notorious, like carbamazepine. Maybe it's radiation. Maybe it's streptomycin. Maybe it's some type of virus like cytomegalovirus, Epstein-Barr virus. Whatever the cause, the myeloid stem cell is being attacked where it's supposed to differentiate out into a red blood cell or a white blood cell or a platelet. So we have not only red blood cells that are affected here, we have low red blood cells, we have low white blood cells, and we have low platelets. This is referred to as pancytopenia, okay? So everything is going to be low with aplastic anemia. So what we have to kind of focus our care and attention on here is really preventing complications. right? So with pancytopenia, when everything is low, obviously we're going to have all the signs and symptoms that you would expect with the anemia. But with low white blood cells, we have an increased risk for infection. Okay, so recognizing and preventing and treating infections very early as they arise is going to be very important. Some signs and symptoms of low platelets obviously is going to be bleeding. So, maybe excessive menses, maybe bleeding gums, maybe epistaxis. You might see petechiae, or little micro hemorrhages on the patient's skin that would clue you into, some excessive bleeding because of the low platelets. So what you would see with aplastic anemia is very low red blood cell count, low reticulocytes. So reticulocytes are immature red blood cells. Reticulocytes are supposed to mature into fully functioning red blood cells. But if that myeloid stem cell, before it differentiates out into anything, is being attacked because of this aplastic anemia, then your immature red blood cells is going to be low. So you'll have a very low reticulocyte count. You'll have a very low absolute neutrophil count. So the neutrophils, is the primary defender of, the white blood cells. So an absolute neutrophil count of less than 500, and you would, need to institute, again, infection prevention measures, and then a platelet count even as low as, 20,000 or less, and obviously bleeding precautions. What are we going to do for these people? Again, we're going to treat signs and symptoms as they arise. The physician may order colony stimulating factors. Nepogen stimulates white blood cell production. Procrit is one that stimulates red blood cell production. Really the only thing that we can do to totally correct is going to be a bone marrow transplant. And the only way to fully diagnose aplastic anemia is a bone marrow aspiration, which would show, low counts of all these blood cells. And then it would also show like where there's fatty tissue replacing, good functioning bone marrow. So a bone marrow biopsy or bone marrow aspiration would be the way to definitively diagnose aplastic anemia. And so that about wraps it up for iron deficiency anemia, B12 and folic acid deficiency, and then finally aplastic anemia. I hope this video has been helpful to you guys. Be sure to look around the website. There's other practice questions. There's tons more videos. There's other resources like full care plans that can help you with your clinical paperwork. And just follow us on Instagram, Nursing School 911. And just thank you so much for watching. I hope you're having a great semester.